and I'm joined by some fabulous colleagues, Professor Dharani Hapangama and Dr. Nicola Tempest and Dawn Heels, who's going to give us some lived experience. So I'm very, very thrilled that we're here because we're going to be talking about fertility and problem periods. And I think that's really, really important because all the Wellbeing of Women team know that I go on and on and on and on about how we've got to talk about periods and fertility, particularly periods, because most girls and women that you and I know have 12 periods a year for 40 years of their lives. So that's a lot of episodes. And we've got to make sure that everybody understands how important it is to ask all girls and women how their periods are, to ensure that going forward in the future, we don't have girls and women not being able to go to school or college or go to work because they're disabled by either their heavy periods or their painful periods. So we've been exploring all sorts of topics in our monthly webinars, and as I say, we've got the model that we like to use is to have a patient or a woman with lived experience telling us about the obstacles and the barriers and the problems, or perhaps even the good care that she's met. We won't always be negative about it. And then we ask some experts to come and help us and give us some insights so that you, the audience on the platform, can feel that at the end of the hour, you've actually really feel very empowered and you know what it is that you need to be asking for. So Nicola Tempest, who specialises in fertility and is one of our Wellbeing of Women funded researchers, and Professor Dharani Hapangama, who specialises in heavy periods and menstrual disorders. And our guest speaker today is Dawn Heels, who's actually a fibroid advocate, who turned her own pain into purpose after sharing her lengthy battle. I think it was about 6 years, wasn't it, with fibroids on social media back in 2022. So I want to say, without wanting to sound the least bit patronising, I think that's very brave of you, and we really appreciate you doing that. And also for any of the members of the audience who've been following the Wellbeing of Women Just a Period campaign, you'll know that Dawn was one of our featured film stars on that. So without further ado, we're going to explore period problems and fertility issues and potential causes and treatments, how these can impact individuals and couples. And then, as the usual code for these webinars, please put your questions into the chat and I will try to address as many of them as we can towards the end of the talk. So remember that you need to keep your sound on mute, or your sound on mute if you're not speaking, so that we don't get echoes as well. And I want to say as well, as my welcome to my fabulous panelists and my thanks to the Wellbeing team for getting this all sorted out, to thank our sponsors, who are the Financial Services Compensation Scheme and Bolt Burden Kemp, because without their sponsorship, it wouldn't be possible to reach all of you on the platform. Rebecca, I don't know if you can tell us how many people we've got registered for this one, or perhaps I can see it when I move into looking at the participants. So I can already see we've got 83 people plus our panelists. So I expect it to be well over 100 by the time we get going. So
150.
150, you see? That's fantastic. Lovely. So I'm going to ask firstly Nicola and then Dharani to give us a brief overview of their work in relation to fertility and heavy bleeding and menstrual disorders, and how it is that they're going to make a contribution to this webinar. So who would like to go first? And then I will invite Dawn to talk about her experience. So Dharani, shall we ask you to go first?
Yes, thank you very much, Leslie, and the Wellbeing of Women's team, and thanks, Dawn, for joining. So I'm Dharani Hapangama. I'm a gynecologist working with, obviously, most of my work is with women having menstrual disorders, and I'm a researcher as well. So for the last 20 years or so, I've been working on very common gynecological conditions like endometriosis, adenomyosis, and fibroids that cause heavy and painful periods. And our approach had been to identify the pathology behind these conditions and how that will affect the lining of the womb, to cause the symptoms, be it heavy periods or difficulties conceiving, etc. And by doing that, our aim is to identify abnormalities specific to those conditions. So then we can use that knowledge either to improve the ways we diagnose these conditions or to try to find new targets so we can develop new treatments which are much more effective than the ones we have. So very happy to be here and grateful for Wellbeing of Women for supporting some of our work as well.
Well, thank you, Dharani. And yes, I should say to our audience that you may think it's surprising that menstrual problems are so poorly researched, but Wellbeing of Women is doing their very best to ensure that we not only do we fund research projects, but we also fund the next generation of researchers, because you can have all the money in the world, but if you don't have the trained researchers who are mustard keen and really, really are on the case and wanting to push the ball forward, like Dharani has been and still is, of course. But I'm going to turn now to Nicola Tempest, because you're at a slightly earlier stage, I think, in your research program and your career. So Nicola, just tell us a little bit about your work and why you're here today.
Yeah, so thank you again for having me as well. It's great, and Wellbeing of Women have been fantastic advocates for my work, and I hope that I have tried to be an advocate for them as well, because I really believe in what they do. Through the Wellbeing of Women, I've managed to do a lot of my research. One of the things being my PhD, which was looking at people with these benign endometrial conditions and stem cells, and looking at various different aspects of that. I've kind of moved to focus a bit more on the pathology, which is what we kind of wanted to do, because we really want to help people. I've focused and become a subspecialist in reproductive medicine. So I'm looking at the women that have got recurrent implantation failure, recurrent miscarriage, that are going through IVF. So where I do lots and lots of surgeries for women that have fibroids. So we collect lots of endometrial samples, and we've lots of ongoing projects. And it's not just that, we were discussing just briefly at the other aspects as well, about what do people know about menstrual conditions, and why don't they know about menstrual conditions, what do people know about fertility, how can we help them with the basic knowledge and the basic understanding of making sure that they're in the optimum position if they do want to get pregnant. And I think that basic knowledge is really needed and really should be pushed, so that people know what's kind of more normal, what's more could potentially need treatment, and how we can help them. So we're looking at different treatment options for women as well.
That's fabulous. Thank you very much. With my particular interest in recurrent pregnancy loss, I know how many times I'm quizzed about implantation failure as well. So really important. Now, I'm going to turn now to the star of our show, who is Dawn, because actually this is what it's all about, the women whom these problems are affecting. So Dawn, would you like to tell us in your words, and in whatever order you choose, your experience of having fibroids and how this impacted on your journey to becoming a parent? And thank you again for all that you've done to support the Just a Period campaign, which has been enormously successful so far. We've had so much positive feedback from it. And I was asked last week, when I was giving evidence at the Women Equalities Select Committee, I was given a gift of a question at the end, and I was asked by the wonderful Caroline Noakes, so what does good look like? And I said, good looks like every girl and woman in this country never missing a day, or being distressed about missing a day at school or college or work because they have painful periods or heavy periods or a combination of both. So over to you, because I know you're going to tell us about how you didn't have that help right at the beginning and how you went about finding it. So thank you, Dawn, for being with us today.
Thank you, Lesley, for your wonderful introduction, and thank you to Wellbeing of Women, who allow me to fly the flag for fibroids. That's my kind of tagline. So thank you, and they're a wonderful charity. So everyone really get onto them. My name is Dawn Heels. I am a fibroid advocate, warrior and campaigner. I share a lot of my journey on Instagram, so you can have a look there. My story is a very long one. So just to start off, so people know how long it is, I am 40 years old today. I'm 40. And when I was 14, I started my periods, and they were very painful and very, very heavy from the jump. So from the jump, they were very heavy. My mum took me to the doctors, and the doctors at the time, when I was a teenager, said that with periods as a teenager, they tend to be very heavy, they tend to be painful, but this will peter out as you get older. So we were like, okay. And actually, my mum had also suffered with very heavy, painful periods as well as a teenager. So we thought this was hereditary. So it was like, okay, fine. They'd given me a tablet. I don't know what this tablet is, but they gave it to me. But I remember as a hormonal teenager, this kind of like sent me into a spiral. My mum was like, you're not taking this anymore. Just, you know, deal with it with ibuprofen, paracetamol, which I did. But then when I got to the age of kind of like 16, 17, 18, girls talking, we found out about the pill. And I found out that this could help alleviate some of my symptoms. So I went to see the doctor and they put me on Cerazette. Cerazette changed my life. It took away my periods. I was living my best life. I literally was, until it came to my 30s. So I hit my 30s, and I knew at that time that some point in that decade, I'm going to want to have children. So let's come off the pill, let the body regulate. Apparently, I'm going to have these amazing periods, right? Because the doctor said, you know, teenage years, let them go by. You're going to be fine. Came off the pill, and I was met with even more horrific, painful, heavy periods. And I couldn't believe it, but I left it. So fast forward to 2016, I was working at a very toxic workplace. I was very stressed, and I started to get a pain in the left-hand side of my abdomen. And this pain was a very different pain. Like, I'd never experienced this before, but I thought maybe it's something to do with my cycle, something to do with my period, because as I said, I had been suffering. So I left it a week or so, and I thought, no, this is different. So I went to my doctor, and he said, actually, it's probably something to do with your cycle. So I thought, okay, yeah, probably it is. Left it a bit, monitored it, and I thought, no, there's something up. And I went back to see him, and he said, no, probably is something to do with your cycle. But I always say to women, you know when something is up with your body, right? And you know there's something up, there's something different. So I bypassed him because he was my registered GP, and I asked to see a female doctor. And I went to see the female doctor. She didn't touch me or anything like that. And she goes, from what you're describing, it sounds like a cyst on your ovary. But the way she said it was very blasé. Now, again, you're in your 30s, you're thinking about kids in the future. And I'm thinking, but I don't want anything wrong with my ovaries or anything like that. And she said, I'll send you for an ultrasound scan at the hospital. Now, this was pre-COVID, so getting a referral was very easy. Within weeks, I was in the hospital, over the belly ultrasound, and the sonographer said to me, ovaries look fine, everything's healthy, but you've got 2 fibroids. And I was like, what fibroids? And she said, you're going to have to make an appointment with your doctor. So off I go back to my registered GP, so to the male doctor. And I said, well, this is what's happened. And he looked at my notes and he said, yes, you have 2 fibroids. They're 4 centimeters in diameter. They're very common, very normal. There's nothing to worry about. Just deal with the pain through ibuprofen and a hot water bottle. He was my GP. I'm going to listen to what he says. It's normal, it's common. Okay, fine, it's no big deal. But for the next 6 years, I suffered. And I suffered in silence because I knew nothing about this condition. From what I had read, I could see there were symptoms. And like I said, my doctor said this was normal. But the symptoms progressed. Very heavy, clotty periods. I had back pain, butt cheek pain. I had a pain that went from my sort of pelvic area all the way down to my toe on my left-hand side. The pelvic pain and the abdominal pain went from one side, so from the left side to the right side, and I just had a full pain. I had a kind of pressure in my belly as well. I was going to the toilet ridiculously amounts. So I had that pressure on the bladder. So if you think about leaving your house and 10 minutes later needing to go to the toilet again, and you haven't had any water or anything like that, and it's full urination. So all the time I was doing that. My belly was protruding. I didn't know what was going on. I was a very, and this is not to toot my own horn or anything like that, I've always been a very slim girl in my stomach. So to watch my belly protrude, I didn't understand what was going on there because I was exercising, eating right. I would bloat ridiculous amounts after I'd eaten. So we all get a little bit of a bloat, right, after we've eaten. But this was extreme. And to the point I was saying to my partner, look, and he'll just be like, whoa, like, what's going on? And I'll talk about other symptoms that progressed as I kind of went up through my journey. But those were the main symptoms and the pain that I was dealing with on a day-to-day basis, that when I was going to work, I was getting stuck in the toilet. So imagine if you're at your desk, you're getting up constantly to go to the toilet, you're in the toilet for 20 minutes, half an hour, you're panicking, because I would literally put a tampon on, I would stand up and you would just feel like a gush and you'd have to change again. You put another one up, you'd have to change again. And I'm in the toilet thinking, my manager's probably thinking I'm on my phone. It was awful. So I kept going back to my doctor and saying to my doctor, I'm suffering with these symptoms. And each and every time he would say, it's normal, it's common, you just deal with it with an ibuprofen. It got to 2020 and I literally couldn't deal with it anymore. And I remember speaking to one of my friends and she said, go and ask him for a transvaginal ultrasound. And this is why it is really good to speak to other people. And it was only because of some things that she'd gone through that she knew about the transvaginal ultrasound. So I begged him to send me to have one, and I went off. And the lady said to me, yes, you've still got 2 fibroids, but they had grown. So they'd grown to 6 and 7 centimeters in diameter at the time. And I said to her, asked her about fertility. I said, you know, this is something I want to have a child. And she said, but I see women all the time with fibroids and they fall pregnant, which is true. But when it's not happening to you, there's obviously a problem. Now, I left that consultation, that kind of that scan, and I was at my wit's end. I was like, you know, what is going on here? And I went back to my doctor and I said, I need to see someone, like I need to see a specialist. And he referred me to a specialist gynecologist who again went up inside of me, had a look, and he said, you have got fibroids that are sitting in the uterine wall. And this is what we believe will be stopping you from becoming pregnant. But instead of dealing with the fibroids, what they did was to send me back to my GP and try and start the kind of fertility journey. So they wanted to send me to a fertility clinic that was within my hospital. But I'm still in pain. The pain's getting worse. No pregnancy is occurring. We're not dealing with the fibroids that I've got, but you want to send me to fertility. And that's when I just couldn't take it anymore. So in 2001, something kind of called me to talk to one of my colleagues at work. And she said, Dawn, remember, we've got private medical healthcare. See if you can do something on that. So with regards to the fertility and the fibroids itself, I went and spoke to them and I was able to see a specialist gynecologist who absolutely changed my life. I went to see him. It was the first time I was being heard, listened to, a plan was put in place. So remember I said to you I had 2 fibroids. When he went and did another transvaginal ultrasound, remember I was in severe pain. He said to me, Dawn, you've got at least 6 fibroids, and one is the size of a grapefruit. So this is the one that was protruding my belly, making me go to the toilet all the time as well. And he reconfirmed that where the fibroids were, it was stopping implantation from happening. So I would have never been able to fall pregnant. And because of how many, where they were and how big, I had to have an open myomectomy operation, which resembles a C-section. And I always say, if I was going to go and have a C-section, I wanted to be giving birth to a child, not giving birth to benign tumors. It's as simple as that. So I was crying. If the walls of my house could speak, they will tell you. So that was in 2021. And at the top of 2022, I had my open myomectomy in the January. And my consultant came to see me the next day. He said, Dawn, it's been a success. It's been amazing. He said, do you want to see how, you know, what we took out of you? I said, yes, let's go for it. He showed me a picture. There was 16 fibroids that he had taken out. And the picture looked like a solar system. You can actually go and see the art on my Instagram page. I couldn't believe it. I really couldn't believe it. I had a tough recovery with my wound. I also had to have a blood transfusion because I had a lot of blood that left me. So I had to have a blood transfusion about 5 days after my operation. But after that, the healing was very, very slow. 8 weeks of really tough healing. I went back to see my consultant at the 6-month mark so he could check everything, and he was happy. At that point in time, little did we know, and I didn't know at the time, I was actually pregnant. So in July of last year, I fell pregnant. So 6 months after, 7 months after my operation, and in March of this year, I gave birth to my absolute blessing, my daughter. My story has a lovely ending, but it's one filled with trauma. I'm very distrusting these days, and that's what I advocate for women, and I tell them you need to speak up about what is going on and not to be dismissed, because had my doctor taken me seriously, I certainly believe that I would have had a less evasive operation. There could have been something else that I could have done. But, you know, at that point in time, the operation I had, it worked and it was successful for me. So ladies, speak up. I always say that, speak up about this problem, and there is help available out there.
So thank you, Dawn, very, very much. Which really, really helpful. And there'll be lots of questions, I'm sure, that we'll come to in the end. Now, one of the things that, one of the reasons why I've taken on this role as being the Women's Health Ambassador for England is because I was so shocked by the public consultation that was started in 2021. And of the 100,000 individuals that responded to the public consultation on what's wrong with women's health, over 80% of the women said that they felt that they'd been ignored or not listened to. So first and foremost on my agenda is making sure that people feel listened to. And I'm going to now turn to Nicola and to Dharani and ask them to help us with their expertise, because there are many different gynecological conditions that can impact on fertility. But one of the things that I keep saying to the civil servants and the ministers that I'm working with, you know, women don't go in to see Dr. Nicola Tempest or Professor Dharani Hapangama or Lesley Regan and say, oh, I've got PCOS or I've got endometriosis or I've got fibroids. So they go in and say, I've got a problem period, or I've got irregular periods, or my periods have disappeared, or my periods are painful, or my periods mean that I've got this terrible, terrible swelling in my tummy, or I can't leave the house because the bleeding is so awful. So we've got to get everybody to be understanding what the red flags are. So tell us a little bit, Nicola, can we start with you about PCOS and endometriosis and fibroids and adenomyosis and how they affect fertility, and I'll come to Dharani.
Yeah, I think, thank you, Dawn, for sharing your story. And the problem with this, and I'm just echoing what Professor Regan has just said, is that nobody asked you what the problem was at the time. They were always thinking about what might be the problem in the future. The problem was that you had heavy, painful periods. So that problem needed dealing with then. It wasn't an issue about fertility in 5 or 10 years' time. It was that you had heavy, painful periods that meant that you couldn't leave a toilet. Like, I think drilling down to the actual question, and I think we have that. People come to the fertility clinic and they actually don't want a child at that time, but they've been referred there because they might want a child at some point. And you're like, well, you're not dealing with the actual problem that they've come to see you with. And I think that listening and actually understanding, what have you come to see with me? What is your problem at the moment is such a big thing, that just the listening, isn't it? So yeah, all of those conditions can impact on fertility, but I overwhelmingly want to say that most of them don't, and most people with any of these conditions will actually get pregnant. And I think, Dawn, you will have seen lots of people that have got fibroids that will get pregnant, and fibroids will affect, say, just fibroids on their own, about 5% of people that won't get pregnant. So most people with fibroids won't have an issue. It's those that are impacting the lining of the womb that we are more concerned about, that we think we need to treat. And a lot of those don't end up in the treatments that Dawn has needed necessarily. And it's just they need an outpatient procedure that will remove the fibroid from the lining of the womb, which is obviously a lot easier to deal with and a lot easier to recover from. There are the minority of people that will need much more invasive operations like yourself, Dawn. But that is the minority, and I really want to stress that most people with fibroids won't need lots of surgeries. There are lots of other conditions, as you mentioned, such as endometriosis and adenomyosis. And again, I just want to say that most people with endometriosis and adenomyosis will get pregnant and won't need to come and see us as fertility doctors. But when you do, or if you did need to come, then that would obviously be, we know that endometriosis affects 1 in 10, but when we see them in a fertility setting, then it's a much higher number. But we still, again, don't advocate lots of operations for these. And I think overwhelmingly people need to make sure that they're in the best, they're living their best self, in a sense that they have made sure that they're eating well, that they're sleeping well, that their BMI is correct. So you're making yourself as healthy as possible with or without these conditions, to ensure that you potentially, if you do need fertility treatment, are going to be eligible and you can get on with it as soon as possible. I hope that went with somewhere.
Really helpful, and you've covered a lot, so that'll allow me now to move on to Dharani. And I wondered, Dharani, whether you could help us with addressing some of the very common misconceptions around period issues and fertility. So, for example, many women tell me that they were told, oh, well, if you've got endometriosis, having a baby's the answer. So unpick that one for me, if you will.
Yeah. Please. So I would say, if you desire to have a baby, having a baby is an answer, but that's not an answer for anything else.
Exactly.
I think the problem is most people in clinical setting, or my colleagues, will anticipate future problems with fertility. So they're not actually like what we heard from Dawn. When we see patients, we don't really think of the problem they're bringing to us, but thinking ahead without listening to the problem in hand. So to say, oh, have a baby and then treatment is going to be easy afterwards, because the available treatments we have for all the conditions we mentioned today, be it fibroids, endometriosis, adenomyosis, and polycystic ovarian syndrome, would mainly involve hormonal treatment from the medical side and surgery from the surgical side, both of which will potentially affect fertility either reversibly or irreversibly. So when you're taking the hormonal medications, although Dawn, I'm very glad you mentioned, Sarah said, really allowed you to have the best life, which it does. You know, quite a lot of the hormonal medications we have are good for some of the treatment, some of the symptoms. But obviously, when you want to conceive, they're contraceptive, so they're not good for that time. But for most of the other times, they are the most likely best treatment that we have got. And then when it comes to surgery, Dawn, you had a very good outcome, but the exact surgery you're talking about can mean that you have to have an emergency hysterectomy, or because of that surgery, there may be complications in mid or late pregnancy. So because of that, if fertility is not an issue, treatments are a little bit
Thank you,
easier.
Dharani. So that's really helpful. And I think what both of our speakers have been emphasizing, and it's a point that Dawn raised in her presentation to us, is that actually it's really important to listen to women and to actually find out what is troubling them and what it is that they want to achieve, not to think, oh, right, I've got a fibroid here, or I've got adenomyosis here, and this is what we do, because it may be very suitable for them to have contraceptive hormonal preparations which will resolve their problems. But for other women, it will be absolutely not appropriate because they want to conceive. So you've got to tackle the problems differently. But if I may, Nicola, could I ask you, where has this old wives' tale about the endometriosis curing the baby having the pregnancy curing the endometriosis? What's the thinking behind that? Because there's a question in the chat about, well, why is that?
So it's about estrogen, and that it's the periods that are causing the pain, basically. So you have endometrial lining of the womb, basically outside of your womb. So that shedding and that inflammation, that tissues sticking to each other, the adhesions, that's what's causing all of the pain. So if you're pregnant, then you're not going to have periods for the 9 months that you're pregnant, and potentially for an extended period after pregnancy, whether you be breastfeeding or not. So it's kind of leaving the endometriosis without its like food source. So a lot of people find when they've got endometriosis that they feel much better when they're pregnant. But obviously you have all the symptoms of pregnancy. So you don't have your endometriosis pain, but actually you do have all the other symptoms of pregnancy. And other people, especially when they've got severe endometriosis, can find that they still have loads of pain because it's the adhesions that's causing the pain. So with a growing abdomen and the adhesions, they're still going to get pain. So I don't think it's like this endometriosis is the cure is pregnancy, but it can help some people because you're not going to have a period.
That's really helpful. Thank you. And I mean, I think the other thing to emphasize here is that the whole point about why it's so painful, the endometriosis, i.e. that's womb lining cells which aren't in the womb cavity anymore, is because our bodies are trained. It's an evolutionary response of when you have blood anywhere else in the pelvis that you get pain, because that's warning you that there may be a problem. So it really is awful, isn't it? Because it gets inflamed every cycle as you go through each menstrual, as you go through each hormonal cycle, I should say, the cells get inflamed and then they start to bleed as well, and then that makes the endometriosis potentially worse. So Dharani, what can people look out for if they're having problems conceiving and getting? What sort of treatments have we got therefore? Or perhaps I should ask Nicola that one, and I'll go on to Dharani about something else.
So if you are trying to get pregnant and you have not been successful in achieving a pregnancy, obviously we see people, depending on the age, after 12 months or 24 months of trying to conceive, you can get investigations before that on the NHS, and if there is any pushback from that, I would just push forward that everybody is entitled to investigations. I think in the first instinct, what people can do from at home is, and especially because the NHS guidance is so rigorous, is that you need to make sure that you're in optimum health. So you can't be smoking, your BMI has got to be less than 30. So you really need to make sure that you're living your best self to be able to conceive, whether that be naturally or through fertility treatment. And then when you come through to the clinic, I would always read up about the clinic and what you're planning to have when you get there. I think some people miss the letters and various different things, but it's really good to be in the know when you get there, so you're asking the right questions, because you need to have the appropriate blood test. Your partner needs to have an appropriate semen analysis if you're with a male partner. And then we would see you to discuss kind of the results of those investigations, to think about what steps need to happen further. It might be that you need ovulation induction if you've got polycystic ovaries, so that's tablets that you can take by mouth. And then if you meet the criteria and it's needed, and then people can go forward for IVF. But it's still a massive postcode lottery, and I think making sure yourself is in the best kind of health they can be will help with fertility, will help with conceiving, but also will make sure you're in the best position for IVF to work when the funding is so limited.
Thank you. That's really, really helpful. So let me turn to Dharani now. And when and how and who should people go to, or women should go to, let's be specific, as a first point of contact when they're concerned about their periods, whether they're trying to get pregnant or not. So I think we want some practical measures as to what's normal and what's abnormal, and where should they go to first and foremost.
I think the GP, our primary care colleagues, are the first port of call, because they can start most of the treatments, and there are specific guidelines to manage this as well. And I would like to think that these are available to all women. I mean, for example, when we were talking about people who are trying to conceive but having heavy and painful periods, you can still use things like tranexamic acid and mefenamic acid. You can use when you are on a period, even when you are trying to conceive, which wouldn't affect the fertility. And if conception is not an issue at the time, they can also start hormonal medications through the GP. But if they're not helping, that's the time they need to be seen by a gynecologist. I think trying those treatments with your GP, but giving a good time. It's not like taking the pill for a week. That's not actually trying. And there are various pills as well, mini pill, combined pill, Mirena coil. All these are available through most of the GPs. And at least 6 months of using them, or 3 months onwards, should be the plan. And if
now, I think, Dharani, a lot of our audience would say, well, my GP says that I can't get a Mirena coil. Now, I mention that specifically because I'm a real advocate for Mirenas. I think they can transform women's lives.
Yes,
so
totally.
I'm so ancient now. I can remember when I was an SHO in gynecology, we used to do umpteen hysterectomies every painful, heavy bleeding. Now, my trainees now all complain about the fact they've no idea how to do a hysterectomy because we have Mirenas and we have all sorts of hormonal things. So
we do 20% less. I mean, 20% hysterectomies compared to 20 years ago because of Mirena.
Exactly. So 4 out of 5 of the ones that were done are no longer necessary. So please, ladies, on the call, our audience, if you've got painful, heavy periods, don't say, oh, I don't want a coil inside me. It's not like the old copper coils, which used to give you pain and cramps and heavier bleeds. Mirenas are really, really transformational. So please, please promise me that even if you've been told by your best friend that they're awful to have coils inside you, just try it because your life could be transformed.
And now, one other thing I have to say about the Mirena, the amount of hormones you take with the Mirena, it's like taking 5 mini pills over 5 years. It's really low dose, really tiny, the maximum benefit.
And what I often say to the ladies I'm talking to is that the womb muscle is so thick that actually it's a perfect place inside the cavity to put the coil because very little of the hormone can actually get through the muscle and into the bloodstream. So it's just a perfect thing. And of course, I will also say, because we've had some questions about menopause here, it's the most wonderful contributor to menopause treatment. So you can take your patches or your gel or your tablets of estrogen and just protect the womb lining with that. And that gives you minimum effects. And even women with blood pressure problems and blood clotting problems can have transdermal estrogen when they're menopausal. But I'm losing track of stuff.
Literally every single person I see, I try and advocate a Mirena for, because I always sell it as, I'm like, it's the doctor's contraception of choice, it's the doctor's HRT of choice. I'm like, I'm just kind of like, honestly, if you have a room full of doctors, they'll all have a Mirena, and if they're female. So therefore, I'm like, come on, we can't all be daft. Like, go for the Mirena.
Now, what I think would be helpful, I hope you agree, Dawn, is I'm now going to ask our two period and fertility experts to think of a couple of points each about what should we ask women or advise women to take with them as information, or what tips should we give them, or what questions should they be asking? What do they need to think about before they go to that special appointment? So I always say to the women who ask my advice, well, write things down, because sometimes when you're in a situation where you think, oh, they may examine me, and perhaps you feel embarrassed or whatever, or you're just agitated because you're in a hospital or a clinic setting, always write things down. And I always also say it's very sensible to take someone with you as well, not because the doctor's going to bite you or anything or be unkind, I hope, but because often you have selective hearing when you're the person with the problem, and your friend or your partner can say then, well, actually what they did say was this, do you remember that? And so you may forget something. So that's my two, write things down and possibly take someone with you for another pair of eyes and ears in the room. Now, Nicola, what would you say? What other things was really useful to take with you when you go for that appointment?
I mean, I totally agree with what you said. I think they're great, great to take with you. I would also always ask when you finish your appointment if they've got any guidance, anything that you can look. So a lot of clinics now will have QR codes that you can scan on your phone, or some paper leaflets, because I think, again, it's that when you get home, you don't want to have forgotten everything that's been said to you. Have you got information that I can take home with me? And make sure that you know what is the primary question that you're going with. Have one specific question. I think when you've been waiting for ages for an appointment, it's really difficult to not get lost in loads of different things that you've Googled and you found out about. But actually, if, for example, when Dawn went to her appointment, she was very specific, like, I can't get off the toilet because my periods are so heavy and I have got loads of pain. It wasn't the fact that the main problem wasn't fertility at that time. So I think having like one very specific question and making sure you feel like that question has been answered when you leave is really important.
Lovely. Dharani, any thoughts?
The other thing is, we talked about several conditions here, and quite a lot of the women have more than one condition causing the symptoms. So maybe asking about them, particularly things like adenomyosis, and making sure that your treatment is addressing all potential conditions you have, sometimes is useful as well. And getting your doctor to explain to you all available treatments, so you make a decision depending on the severity or side effects as you feel acceptable or not. So not just accepting, just one thing, and to have a kind of long-term plan for the condition as well.
Thank you. Now, I'm going to just challenge our speakers just for a moment, because Paulette and I think Amber have questioned. They've said, well, actually, why, with all due respect, is the question, you're talking about treatment for heavy periods, but not trying to tackle the cause of what is causing the issues. So how do we address the root cause? Which is a fair enough question. And we should probably actually explain that, you know, we know that fibroids and adenomyosis and endometriosis are associated with heavy periods, but often we can't find a reason. I mean, I must say as well, I've identified 2 women just in the last 2 weeks who've actually got a blood clotting disorder that makes them actually more likely to bleed. Now, that's incredibly rare, but I have to say that they're incredibly grateful that we've identified it, so we may be able to do something about that. But Nicola, back to you. The challenge, I think, is there that, you know, why aren't we getting to the root cause? And that's really why we're funding all this research, isn't it? Because we need to understand more about the mechanisms.
Yeah, I think understanding more about the mechanism behind the conditions is paramount. And I totally agree where people are coming from, in all due respect, when they're saying about, we're talking about treatment. But I think first and foremost, as a medic, I kind of want to ensure that people are being able to live their best life, as we've been saying. Like, it's all right us saying that you've got fibroids, but we actually do need to think about the treatment for those. And a lot of the treatment for any of these benign endometrial conditions are the same. Therefore, if we think you have potentially got endometriosis, then treating the condition, and if you're happy with the treatment and it's making you be very well, then we wouldn't advocate a surgery in that situation to diagnose a condition. That's why there's lots of research ongoing with regards to how we diagnose conditions without having to do surgeries, which at the moment we can't do. So I think if you have a normal ultrasound and a normal examination, then actually trying these hormonal treatments is a good first option if you don't want to get pregnant, because we want you to be able to live a fulfilling life, rather than kind of being like, let's nail everything down to potentially it's adenomyosis. Well, if we tell you you've got adenomyosis, we can't say, but here's a magic pill that's going to cure it. So we want to try and think of what's the best thing for you to be having, so that you can be as well as you can be.
Thank you.
I would like to add something more here. I totally get it. The ideal thing would be to go to the root cause, but as our understanding about these conditions are at the moment, we don't really have very good treatment. So there comes the need for funding and research, and this is what we are trying to do. For example, when it comes to fibroids, Dawn talked about, there are different types of fibroids. How each one of them are causing the symptoms, we are yet to know. We don't really, our understanding about these very common conditions, as common as diabetes or asthma, are very limited. So there is a lot to be done. Funding needs to be there for research, and but until then, we have to use the treatments we have got to the best of our ability.
Now, can I come back to you, Dawn, and ask if there are any questions that you would like to pose to our expert panelists at the moment, or any of the questions that you'd like to address? I mean, there are lots of questions about very specific issues, and I'm delighted to hear that some people have had a very good experience with Mirena. And in response to the question about why I hope it's the doctors who have this, it's because I think doctors know an awful lot about what a wonderful response you can get to Mirena. So they say, well, I won't bother with all the others, I'll go straight for that. Now, coming back to you, Dawn, do you think there's anything that you would like to specifically ask our experts that we haven't covered?
We've covered a lot. I think speaking to ladies, which I do on a daily basis, who've got fibroids, I think the frustration is the lack of research and what has been doing. I know Professor Dharani, you are in that world. So I don't know if you can shed light on anything that's been done with regards to fibroid research.
We are trying to understand the actual pathology in different types of fibroids and how they affect the lining of the womb or the muscle wall of the womb. But
the person who identifies what causes a fibroid is about to run off to Stockholm to get their Nobel Prize. That's the bottom line. So
exactly.
It's the commonest tumor, commonest pelvic tumor. And, you know, they're incredibly common. And as you well know, Dawn, if you're African or Afro-Caribbean, you're more likely to have them, and worryingly at an earlier age, which is more likely then to affect your fertility. There's some questions about polycystic ovaries, and a lady, it's Lucy, was worried that she'd been advised to go back on the pill because she was having irregular periods, but there is nothing that's going to be damaging to your fertility about that, Lucy.
No, stay on the pill.
I would argue that if you're having irregular, and possibly very infrequent periods on your polycystic ovaries, you really should be on the pill, because you need to have the right doses of estrogen to protect your bones in the long term. And your polycystic ovaries is probably not going to go away. So you need to be thinking about all those. So please don't think that, in quotes, masking your cycle means that you're doing damage. It's not going to affect your fertility, and it's giving you the ideal dosages of hormone each month to keep other bodily systems, not just your reproductive system, healthy. So I think that's an important one. And thank you for the question, because it gives us the opportunity to respond to it.
Protects the lining of your womb as well. We want you to be having periods or no periods with a Mirena in to protect that lining of the womb. We do see numerous people coming through to fertility clinic that actually won't have had a period for a long time because of PCOS. We do a scan, a hysteroscopy, and then they have hyperplasia, atypical hyperplasia. So it's actually really important that people are having periods, 4 to 5 periods a year, or you've got a Mirena in that's protecting the lining of your womb. So I think that's another.
No, it's very important, and that's and also not getting polyps and things like that, and remembering that often fertility patients may have a little bit too much, relatively too much estrogen, and therefore protecting the womb lining is really very important too. There's a question as well about metformin and polycystic ovaries. Would anyone like to address that question?
So we do use metformin, and we use, there's I don't know, obviously that is on prescription, but you can buy other medications over the counter that have been proven to help regulate periods, such as inositol, and they kind of help to regulate your cycle. Metformin we use as part of fertility treatment sometimes, but we don't put it on, we don't give it to people unless they're planning for a pregnancy to treat PCOS from our side.
Great. Okay, thank you. And the question from Amber: I was told that the pill would not be good for me if I have adeno and endometriosis. Well, I hope now that that's actually quite the opposite of the truth. They're likely to be helpful. They may not be sufficient to completely control your symptoms, but they would certainly be one of the first ports of call to try. And then, of course, you know what I'm going to say next, and then try a Mirena, because that'll really change your life, I think. And a question about painful insertion. Well, I'm sorry you had a painful insertion. If anyone's seen the contraception Channel 4 documentary that Davina McCall launched last June, you'll see that I changed her Mirena for her on screen, and she referred to me as fairy fingers after that. So it doesn't, and I'm not saying it to say, oh, clever me, it's just that it doesn't have to be painful. And there's all sorts of things that one can do, using Instilogel to put into the vagina, or putting in an injection that will help with the pain, and also talking women through it step by step about what you're doing is really important. And I'm not in any way negating the importance of analgesia and good pain relief, but if someone's explaining to you what they're doing all the time, you don't think, because you can't see what's happening because you're lying there, and it's very scary. And of course, when we're scared or we're frightened, that's when our pain thresholds become much higher. Well, not thresholds become higher, we're exposed to more pain. So I think that's important too. I wanted to say a few words just before we finish about how the Wellbeing of Women team are really wanting to hear from you in the audience. Please send your case histories and your stories into the website, because in our Just a Period campaign, we want to continue including more and more real life stories so that we can really be representing what you're needing and what you're experiencing. And you'll find, I think, that often when you go onto the website and you read those case histories, you say, oh, well, that's like me. And then you can get so much reassurance by actually understanding that. So please go on to the wellbeingofwomen.org.uk /get involved /donate, because if you donate to the Wellbeing charity, we're going to be able to fund more researchers like the wonderful Nicola Tempest and the wonderful Dharani Hapangama in the future, and not just for these period problems, but also for lots of other gynaecological problems across the woman's life course. So I have to make sure that we finish this just before 1 o'clock, because otherwise I get shouted at, because we have to finish at a certain time. But can you all in the audience join with me and thank our wonderful speakers, our fabulous patient, Dawn, and our two specialists, Nicola and Dharani, who've given us so much help and reassurance and understanding. I think that if I'm not a gynecologist myself, I would feel very reassured that we had fibroid advocates like Dawn and specialists doing research into menstrual problems like Nicola and Dharani. So my applause to all of you, and thank you very much everyone for joining, and thank you Wellbeing of Women team for hosting the webinar and organising all the electronics. So I wish you a very, very happy rest of Tuesday. And please come to more of our Wellbeing of Women webinars, because they're here for you, and you will be able to see this one in the future if you go onto YouTube and just look us up. Or if you don't want to do that, you can go onto our website and you'll be directed to it. So lots and lots of thank yous from a very, very appreciative audience. Things like, thank goodness this exists. Thank you so much. I've learned so much. What a wonderful topic. So we'll do it again, and we will respond to all your requests for more information about this really important problem. So thank you, everybody, and I wish you the best for the rest of the day, and I look forward to seeing you again soon. Bye-bye.
Thank you. Thank you.
Bye.
Bye.
Bye-bye.